Thank you very much, President Connolly. So now on to our keynote address. Each year, we have this challenge of trying to identify the keynote speaker to provide an interesting and stimulating talk that somehow relates to Invest in Children's work. And in the past 3 years, for those of you who've been at the meetings, we've flown in people to give talks on federal policy, on early childhood trauma and its impact, on the long-term positive impact of early childhood education. And this year we decided to do something different, which is focused directly on Invest in Children, and we just needed to go right down the street to get our national experts, who happen to be our team of evaluators from Case Western Reserve University. We're really very fortunate to have an outstanding evaluation team at the Mandel School of Applied Social Sciences at Case, led by Drs. Claudia Coulton and Rob Fischer. Dr. Coulton is the Lillian F. Harris Professor of Urban Social Research, as well as the co-director of the Center on Urban Poverty and Community Development at MSAS. She's a national leader in efforts to enable data-driven approaches to community change. And this year she was named as a distinguished professor at Case, and that is a very big deal. So we're delighted to have Claudia, along with Dr. Rob Fischer, who's Research Associate Professor at MSAS. He co-directs with Claudia the Center on Urban Poverty and Community Development. He's also the director of the Master of Nonprofit Organization degree program at MSAS. He's led many evaluation research studies, in addition to leading the evaluation team for Invest in Children for the past 11 years. He's also the 2011 recipient of the Roberta O'Keeffe Service Award from the Ohio Program Evaluators Group. And we are so delighted to have them here today to tell you a little bit more about the impact of Invest in Children. I think, Rob, you're leading off, so welcome. Thank you.
Good morning. It's a real pleasure to be with you this morning, and I'm going to lead us off, and then Dr. Coulton will come up and share some additional comments. I want to put my request out there for creating a video with kids talking about data for next year, because I think that'd be tremendously effective. But in the meantime, I'm going to try to juicify the data discussion this morning, because I know that this is as we talk about data, all of you know this from your work life. These days, everything is data-driven, data-informed, whatever you can do to make the sense of data. And I think you've probably heard Rebecca Dorman say something like, data don't drive decisions. It's people with data that drive decisions. So don't let us forget that the leadership here in this county and in this room are the ones that have required and demanded data to inform action. So, in a way, we keep the books for the initiative, at least the outcome books, but it's really trying to just reflect the good reality on the ground for so many of the programs that have been working over this last decade plus. So just to give you a sense of where we're headed, and I apologize for my turning neck here, and where am I going to point this? There we go. So we're just going to talk briefly about kind of getting us up to speed where we are with building and completing an agenda for an initiative, talk about some of the highlights from the program evaluation over the last 10 years, and then also we want to make sure everyone here is aware of the tremendous investment in back-end data, what we're calling an integrated data system, about children in our county that is really a resource that did not exist before Invest in Children, and something we should all be thinking about as we try to answer those complicated questions that face our families in this community. So just to remind us, coming forward from 1999, I came to Cleveland in 2001, and this has been my part of my life's work since then. I've added 2 children to my family since coming to Cleveland. But back in '99, when this partnership was created, it was created as a 3-year initiative, so my wife thought we were coming for 3 years. That changed. But really, what is distinctive, continues to be distinctive about the work here in Cuyahoga County is the emphasis on public-private. And when we talk around the country about the work here in the community, they always get hung up on that reference. They ask more about that because too often it is either public or private. It does not reflect the community as a whole. And then coming forward, as the initiative evolved, really a key part there was the strategic planning work that occurred in 2003, and then the formation of the Office of Early Childhood, which became the cradle for the set of programs that now are deployed in the community. And then I would like to suggest that where we stand today is we have a better system that uses data to inform practice. And I hope that by the end of the comments this morning, you'll agree with that. Now, the next one, don't shriek, because many of you have seen this, and you don't have to study it. But this is the so-called logic model for this initiative. And what I want you to take away from it, other than it has a disturbing green color to it, is that it reflects a vision about a system for serving children, something that did not really come together prior to the conception of the initial early childhood initiative. And what you'll see here is those goals on the left, those 4 goals that Rebecca talked about. And then in the middle, you'll see the translation of those goals into on-the-ground programs. And then what I really want to remind us about is on the far right there, you'll see 2 boxes. One which says positive movement on community-level child well-being indicators, which I think we all have to believe that collectively, collective impact says that we want to drive community-level indicators of well-being. And then the second one is community ethic around our youngest children, which I think every speaker so far this morning has talked about. And it really has changed the dialogue in this community about everybody being on the same page about promoting the sense of commitment to children. So that's the vision of the system. Now I want to take you back over the first 5-6 years of the initiative and say a little bit about what we've done with evaluation. So as you know from the goals of this initiative, Effective Parenting, there were really 2 programs that initially came under that rubric, and that was the newborn home visit and the ongoing home visiting. And now every part of the initiative has been the subject of evaluation. So some of these data are a little bit earlier, some are more recent, but I just want to remind you the kinds of things we've learned about this work. For example, with the newborn home visit, we've seen the parents themselves have been able to report to us. You might say, well, that's just a 2-hour visit. We had one at my family, and I know it's partly the getting a visit, it's partly what's in the visit, but it's partly the timing of the visit, right? It's that moment after you come home from the hospital when you're receptive to a rational voice. And if you know, when I use that word, you may have met my mother-in-law. She was not the voice that we needed at that moment. So having that nurse come talk to you about your situation, what made sense in that space and time. And those families routinely tell us about significant improvements in their knowledge about resources and particularly how to deal with their individual baby's health and wellness. And we've also known from this that these nurses in that visit have identified significant numbers of health risks to mom and baby that, had they not been identified at that moment, would have likely resulted in stays in hospitals, ER visits, and we've run those numbers, cost numbers, and the payoff from a relatively inexpensive home visit and the cost avoidance on the healthcare end, it's just the most kind of sensible investment to make. And then on the ongoing home visiting, those families that then have multiple risks and engage in home visiting over time, we've seen improved measures of parental competence and comfort in caring for their child's needs, reduced stress, reduced risk for physical abuse in these children. So we know that home visiting can work. The challenge is always, how do you engage these families in a meaningful set of visits over time. And we also see things like higher rates of immunization and access to regular health care for those families. So this is going to be a fast shot here. In the second category around healthy children, at the early stage of the initiative, the focus was really on healthcare outreach through Healthy Start. And what we saw from that is dramatic increases in the percentage of young children that were getting enrolled in Medicaid. And that was really the investment, was doing effective outreach to families with newborns and prenatally to make sure that they were getting their, if they were eligible, getting them onto public health care. And we also saw the insurance rate in the county go almost to the ceiling and has hovered right around 96, 98% in more recent data. So extreme healthcare coverage. Now make a mental note of that. We will come back to talk a little bit further about the challenge on healthy children. And then the last goal area that I'm going to talk about is on quality child care. And 2 points here, one around the investments that have been made in the family child care system through technical assistance, consultation, and training. What we have clearly seen is meaningful increasing quality among providers in the family child care system. That's partly accomplished through identifying folks who want to make a career of this and investing in them, and also helping people who maybe this is not their career path find another way to move forward. We've seen standardized scores on quality go up. We've seen increasing numbers of Gold Seal homes, which are those top quality programs. And then we also know that homes show more improvement as they get and accept more technical assistance and support in being a better care provider. So those things, again, goes back to that engagement issue that we know continues to be critical throughout this picture. And then secondly, I want to mention special needs child care. And in this program, we've done a series of evaluations over the years, and I just would highlight, you know, the high rate of children that if their teacher engages with a consultation, in consultation about the needs of that special needs child, we get on the order of 90+% of these children able to be maintained in their regular child care setting after that. So many of these kids are at risk of expulsion, but if it can be timed well and meet the needs of that child care teacher, they can almost all be maintained. And certainly some parental choice will play a role here as well. Many parents will still make a choice to go to another facility, which we certainly support. And then we have also learned how to do better parent engagement with this service, how to keep parents informed of what's going on in a classroom setting between their child and the teacher, and how that relationship can be negotiated and a parent can be engaged in making sure they're aware and participating and supporting that model. So those are the flagship programs from the commencement of the initiative. Now flash forward a bit and think about the things that have come online since really since 2005. We have early childhood mental health. We have a primary lead prevention pilot. We have the UPK program, which we've just heard about. And each one of these, so these pilots were each examined before expansion, before inclusion in the initiative. And in the case of early childhood mental health, we clearly see from parents declines in child behavior problems, improved parent-child relationships, over 2/3 of the families meeting their treatment goals as part of that engagement in ECMH. So, and that is a program that continues to be integrated into the service network. A study done by my colleague Lila Jackson looking at the primary lead prevention pilot clearly showed decreased lead dust in the homes where the interventions were conducted. And a key part here was educating parents how to protect their infant from lead dust in those homes. And the knowledge and the use of prevention activities, dramatic improvements there. And then ultimately reduced blood lead levels in those children in the home. And I think I mean, we all know, and this is such a critical issue for our community, how to not only entirely avoid lead exposure for infants and their siblings, but how to, once that has occurred, how to make sure the treatment and response is appropriate for that exposure. And then lastly, the UPK pilot. And here we have, we're in our third or fourth year now with a set of providers providing this high-quality pre-K experience for kids. And we've linked data, and Claudia will mention this in a moment, but we've looked at site quality, and in these programs, they've dramatically increased through the investment of the county. And then we have also looked at how those children fare going forward from UPK settings into kindergarten, into public school kindergarten at CMSD, and we see a dramatic difference from these kids, these high-risk kids that leave a UPK setting and then arrive at CMSD on a measure of kindergarten readiness related to literacy. Okay, now some of you probably remember that I said, remember that thing about child health? So I want to share with you one example that might illustrate how data have played a role in informing program and practice. After this. Forgot about this slide. Sorry about that. Okay, well, just to give you a sense of the magnitude of the initiative, these are recent data from the set of services that are included in Invest in Children, over 120,000 children served since its inception. You get a sense of the magnitude on the far right, total quantities, and you can see data there for 2011. So that total number around 13,000, the number you should have in mind is about 90,000 children in the county under age 6. So we're reaching about 15% of the kids. Now, is that good? Well, remember, so many of these services are targeted to families with particular needs. So it's not like we should expect this to be a high percentage, but these are tailored and targeted services. So, but that's a substantial number of children, and as you look at these data year to year, you see many of them are involved for multiple years at a time, as you would expect, which is a marker of success. All right, so I'm going to make this plug, and I'm just going to quickly go over this. We've been using data to inform program development, new programs. We've been using data to inform program refinement, so partly using data, but partly using the expertise of the staff that deliver these services to inform how can we better do outreach, how can we better accomplish engagement of families, and then also program targeting. So now I want to share with you that example, the power of data on child health. So from the very beginning, we showed this dramatic increase in health insurance coverage in Cuyahoga County for children under age 6. Hooray. But wait, only 43% of children get all the recommended well-child visits in the first year of life. Oh no. So we knew health insurance coverage, great thing, that's a requirement, prereq for getting those well-child visits, but less than half were getting them, at least in their entirety. So going to the data, we looked and we found that nearly half of these families who missed their well-child visits were involved with other IIC services at the point of birth. So maybe we could use that program connection that exists to do outreach to those families. I say again, hooray. But wait. Due to data lags, and those of you that know, I mean, you create the data, it comes to us, we have to work with it. It might be a year later. So due to those things and coordination issues, it's too late. You can't intervene on a missed well-child visit that late, so that would not be effective. Oh no, but wait, one more. We could use a preventative approach by having dedicated staff at clinics reach out to families. And voila, the birth of the medical home pilot with partners Neon and Neighborhood Family Practice, using a single patient advocate at each site. And what they found, again from data, we found that 86% of their families completed all the scheduled well child visits in the first year of life, and that was over double the rate for other children on Medicaid at this same time. So fantastic results from the pilot, and what we now know is that in both of these cases, both of these agencies have been able to carry forward the use of this patient advocacy model in their work. And specifically, Neighborhood Family Practice has now 9 patient advocates working with families, and NEON has acquired federal funding to include the patient advocacy model in their services. So, you know, an ability to use data to inform practice. You can see how the road has twisted and turned, though. You feel good one day, and then you realize the next day that it might be a cul-de-sac that you've entered. So, all right, now I'm going to pass it to my colleague, and I'll come back in a moment.
Thank you, Rob. I want to say that one of the great benefits of Invest in Children has been to bring a nationally known evaluator like Rob to Cleveland and Ohio to live and work, and we have to keep IIC going strong so that we can keep our nationally known evaluator here. No, he's involved with so many things now. He's permanent resident, I hope. I have the enviable task of talking about an even more technical matter, but we think it's very important to get across to this audience that a program, a system-wide program as complicated as Invest in Children requires big data to do this kind of data-driven work and constantly improving the programs and constantly keeping our eyes on the collective impact of it all. And so we have built a resource as a result, which is called here the CHILD system, but it refers to the Childhood Integrated Longitudinal Data System. And it's a resource not just now for this initiative, but for really everything to do with children, even extending now to career and college is the vision for how long a view we really want to take about early childhood. Because why are we investing in very young children? It's so that they get a good start in life, which we don't want to see stall out when they enter school, but we want to really see them develop successfully on into transitioning to adulthood. The idea of integrated data is that we have to break down the silos not only in our practice, but in our data. Data exist in silos in every agency, every office, every part of government that is part of this initiative. And we are using this method of bringing those data together so we can see not only the child's life in a longitudinal perspective, but see across the silos of data and across the agencies. You're probably reading more and hearing more about a concept of big data, and it's not only getting attention nationally, but this idea of having integrated data of this type is being tested and tried in more and more places. And I'm happy to say that Cuyahoga County is on the map as one of those places where we're pretty far ahead with not only bringing data together, but using it to act collectively to have impact for young children. One of the most important power advantages of big data, I said, is to be able to move across silos and to look at longer-term outcomes than any one of these systems or organizations could look at on their own. Sorry about having to move my slides around, but this particular chart is intended to just get across the idea that even within the Invest in Children initiative itself, most children are involved in multiple services. So at a minimum, we have to integrate the Invest in Children service information together to get at that. So how did we get involved with this? We, at the beginning of the initiative, we started putting together the data from multiple sources. We start with the 1992 birth cohort. 1992 birth cohort was started with because the initiative went into effect in 1998, and the focus was on children birth through 6 at that time. We draw routinely on various administrative data sets and put them into the system using a linkage method. And now we're expanding the system to not only look at children's information up to age 6, but now on into elementary school, high school, and on the drawing board is college and career. These are just some examples of the data sources that are currently being linked into the longitudinal system: birth certificates, death certificates, a number of pieces of information about children's involvement with child welfare, foster care, child abuse and neglect incidents, other types of placements and services, indicators from public school records, attendance, kindergarten readiness, the proficiency tests, graduation, information on public assistance systems participation, Medicaid, SNAP benefits, TANF-free seat, child care vouchers, homeless services episodes, and of course Invest in Children program participation, juvenile justice involvement, and all the data are integrated with geodata. So everything's geocoded so it can be examined by neighborhood, by county council district, by suburban municipality, and so forth. There's a lot of technology that underlies such a system. This is just a picture of how data flows in, how it's cleaned, how it's linked, and ultimately how it can be utilized for some of the reports that Rob has mentioned and for additional studies that I won't go into in the interest of time.
Yes. So I'm coming back just for a minute to kind of bring us to a close. All this investment in data doesn't make a difference unless you use the data to answer real questions. So just to quickly hit a couple of highlights in that regard, recently we worked on an application for federal funding for housing for children in high-risk families. And just, if you can't see this, what we found was that about half of the children who had homeless stays in a county shelter in a 2-year period were also involved with DCFS in our county at the same time. And that became the target for this funding application, and the partners identified that group. We were able to put a number to it. We were able to see where they were and better understand the nature of the need to inform that work. Certainly a big part of what we do is looking geographically. We've put out a series of district profiles for every county council. You'll see here a couple examples. So this is tabular data that shows a couple of council districts. You'll see the blue and red. Blue means that district has a rate that is more favorable than the county. Red means it is less favorable on that indicator than the county. So this is, again, gives you a sense of where child need is in the county. Another way to do this would be to look at maps. We do a lot of maps. You'll see child poverty on the left there, and on the right you'll see the rate of receipt of newborn home visiting programs. And then something very specific, but answering a specific question like, what do CMSD kindergartens, what does a class look like? And using integrated data, we can tell, and we did this for a recent entry cohort at CMSD, What percentage had a DCFS involvement prior to kindergarten? What percent of their families were involved with various public assistance programs? So for planning purposes and better understanding the needs of those entering cohorts, this is very useful. And imagine for a moment any program population that you work with. We could use the integrated data to match against all the other experiences that are represented in this data set to better understand the challenges that those families have faced, and then certainly their use of supporting services. All right, so here's the summary. We firmly believe that IIC is a leading example and in a way unique across the country of doing this kind of work for young children, and we have a record of demonstrated impact both at the program level and at the collective. IIC is ahead of the curve in really this notion that we should focus on place and the importance of where services occur in relation to where families live. And then we have created this data system that we firmly believe is a community resource. And then just the last thing, where are we headed now? Claudia mentioned the idea that we extend this system to later adolescent, including more school data, juvenile court records, entry to college. So, and with things like Promise Neighborhood and those many-year notion of programming, it's important that you have that continuous data to better understand experiences. In the short term, what you might look for is we are doing a study of looking at children born in our county and following them to 3rd grade to see how they perform, what factors in their early life predict success on 3rd grade proficiency. And this is related to the governor's reading guarantee. So we're doing that with special funding from the Ohio Educational Research Consortium. And then we're also looking at ways to make these data more accessible to you in aggregate form through something akin to the Neo-Can-Do system, which we already have at our center, how we could make aggregate data accessible. So if you wanted to go online and look up how many kids got this kind of service or that kind of service in a given period, you could do that. So that's our dream. Thank you for being a part of this. Thank you for your tolerance of data at this hour of the day. I think I speak for Claudia and myself that it has been a tremendous experience working with these partners in this way, to be able to see a partnership committed to data, committed to the use of data is honestly a rare thing, particularly given when this started. The commitment now is no surprise because everyone's feet to the fire, but we have such an advance over so many initiatives around the country. So thank you for your time this morning.